This is Jodi Segal at Johns Hopkins University. I'm here to discuss what is comparative effectiveness research. In this very brief video, we aim to define comparative effectiveness research, explain briefly how it came to be, and how it has become nearly synonymous with patient-centered outcomes research. Here is the definition of comparative effectiveness research that was set out by the Institute of Medicine in 2009. They said that comparative effectiveness research is the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor a clinical condition to improve the delivery of care. The purpose of comparative effectiveness research is to assist consumers, clinicians, purchasers, and policymakers to make informed decisions that will improve health care at both the individual and population levels. Included in this definition is the notion that something is being compared and that the information is to be used for decision making. This is not basic science to generate new knowledge about mechanisms. This is knowledge for decision making. There were two big forces which led to the prominence of comparative effectiveness research. One was the drive to deliver clinical care based on evidence rather than upon expert opinion or upon tradition. This mindset came to prominence in the 1980s and led to the development of the U.S. Preventative Services Task Force in 1984 and the Cochrane Collaboration in 1993. This was soon followed by the Evidence-Based Practice Centers of the Agency for Healthcare Research and Quality in 1998. Paralleling this was the work of John Wenberg and Elliot Fisher and others on small area variations in spending and outcomes without clear relationships between the two. This led others to conclude that it should be possible to improve the effectiveness of care while containing costs. The drive for evidence and the drive for cost containment, among other things, led to this report from the Congressional Budget Office in 2007. They published research on the comparative effectiveness of medical treatments. And the premise of this document was that it is possible to constrain healthcare costs, both in the public programs and in the rest of the health system, without adverse health consequences. So this report was advocating for research on the comparative effectiveness of medical treatments. And they said that perhaps the most compelling evidence is this substantial geographic differences in spending, which don't translate into higher life expectancy or really any other measured improvement in health statistics in the higher spending regions. And they noted that hard evidence is often unavailable about which treatments work best for which patients and whether the added benefits of more effective but more expensive services are warranted. So therefore, the goal of comparative effectiveness research is to generate better information about the risks and benefits and costs of different treatment options, which could eventually alter the way in which medicine is practiced and yield lower healthcare spending without having adverse effects on health. The Recovery Act of 2009 had a surprising and powerful effect on comparative effectiveness research. How, you may ask? By providing $1.1 billion into this type of research. This was soon followed by the Patient Protection and Affordable Care Act of 2010, which included a section entitled Patient-Centered Outcomes Research. And in the legislation, it states the terms comparative clinical effectiveness research means research evaluating comparing health outcomes and the clinical effectiveness, risks, and benefits of two or more medical treatments. The key items in Section 6301 included, among other things, the establishment of PCORI, the Patient-Centered Outcomes Research Institute. So importantly, this is not an agency of the government. Its mission is to assist patients, clinicians, purchasers, and policymakers in making informed health decisions by advancing the quality and relevance of evidence concerning the manner in which diseases, can effectively and appropriately be prevented, diagnosed, and treated through research and evidence synthesis, and then dissemination of these research findings. So this sounds very much like comparative effectiveness research with a name change, and indeed it is. And subsequently, the Methods Committee of PCORI was tasked with generating a definition of patient-centered outcomes research. The Methodology Committee said that patient-centered outcomes research helps people and their caregivers communicate and make informed healthcare decisions, allowing their voices to be heard in assessing the value of healthcare options. And this type of research answers patient-centered questions, such as, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? These may be questions like prognosis. What are my options, and what are the potential benefits and harms of these options? Or decision makers need to have answered to make decisions about interventions. And it uses the tools of systematic review and evidence synthesis, observational studies for evaluating effectiveness and safety, pragmatic clinical trials, modeling, as well as implementation research to get the information into the hands of those who need it. This is comparative effectiveness research.